and thank you very much for attending this, what will prove to be a wonderful webinar uh, run by Acumentice. And I'm Sean Duggan. Will introduce myself in a minute. Really warm welcome to everybody. Thanks for attending, joining the webinar. We'll start as people will join over the next couple of minutes. Just a couple of housekeeping points. If we could ask you to submit your questions in the question and answer session throughout, because we'll collect those and come back to them at the end of the webinar. And a recording of today's webinar will be made available pretty shortly after today's session. So this is part 2 of a series of 3 parts, really examining how do we solve a problem like community mental health waiting times. And this part today is going to focus on how to manage waiting lists effectively and why it's so vital to the service user experience. I mean, a quick word of, I had a couple of national meetings yesterday, and with our new government now in play, the health secretary was talking about at a meeting, I think last week, about waiting times as their main priority. And when questioned about does that include mental health, he said yes. And that's always been, I think, a contention, really, that, we have various standards and often they're applicable to acute services, hospitals, and we need to get the mental health there into a sharp focus. So we'll push for that. We'll continue to push for that. But this means mental health as well. So I'm chair of Sussex Partnership Trust, Mental Health Trust, and I'm still doing a bit of work for the NHS Confederation Mental Health Network. That was my former job. Moving from that over the next month or so, and this topic is really important to me. Has always been a bit of a priority, and I think the community mental health transformation is an excellent thing, but we've got to manage it effectively. Can I ask our 2 speakers to introduce themselves? Michael Watson.
Thanks, Sean. So good afternoon. My name is Michael Watson. I've been principal consultant at Acumentice since last August. And before that, I spent almost 10 years working in the intensive support team for mental health at NHS England, where I helped support dozens of mental health trusts and VCSE providers in terms of their talking therapies, some young people's mental health, EIP, eating disorders, and other community services. Before that, I spent nearly 5 years working in the acute version of the intensive support team. Since joining Acumentice, my main work has been leading the elective recovery programme in an acute trust, where we used waiting list management and reporting principles to tackle a waiting list of over 60,000 people. And over the 9 months I was there, we actually saw a reduction of over 10,000 people from their waiting list. Since then, I've been delivering our waiting time readiness assessment support to the Mental Health Trust to ensure that they've got the foundations needed to manage and report against the new waiting time standards for community mental health. Joe.
Well, I think you've every right to be one of our speakers, Michael. So thanks for that. And yeah, the wonderful Joe Hillier. Yeah.
Yeah, that makes that quite difficult to follow up, doesn't it? So I'm Jo Hillier, and I'm the Chief Clinical Information Officer at Sussex Partnership. And I have been managing waiting lists, I would say, probably for at least 15 years of my career, which is where I met Michael actually when he was in the intensive support team, and received lots of support around waiting times for children and young people. In my current role, which is trust-wide, I've just completed my dissertation on what are the best practices for waiting times and community mental health, and that was really fueled, that kind of a huge piece of work was fueled by my passion for this as a clinical and safety issue, and something that kind of really speaks to me as both a person whose family uses our services, but also as a clinician who works within them.
Fantastic. Great. Well, look, why don't we get straight into it and ask Michael to recap on the webinar 1 and also get into the issues around why it's so important for the patient experience, and have some wisdom about managing waiting lists. Michael.
Thank you, Sean. So on the last webinar, we heard some moving stories from a working GP talking on behalf of his patients about the human impact of convoluted pathways, long waits, and poor communication for people needing access to community mental health services. I talked about how people from different areas and different backgrounds experience a variation in waiting times, how data quality is poor, and that this makes managing and improving waiting times much more challenging. If we don't know who's waiting the longest, we can't act to make things better. I don't just mean looking at one individual, but looking as a system. If we can't evidence where we have bottlenecks, if we can't prove the scale of the problem, then we can't make a convincing case for investment and for change. Parity of esteem between physical and mental health and the leap forward in data that are required to get there is a priority nationally. But I have to emphasise again that there are some things which are out of our control. There are fundamental issues with workforce and investment in mental health, which no amount of better management can change. But that doesn't mean that we can't act on those things which are within our control, making the most efficient and effective use of what we've got and using data to make that case for change stronger. So in terms of what we're going to cover today, I'm going to talk a bit to you about pathways and transparency, some of the principles of managing waiting times, and then Joe will talk to you about clinical engagement and safety. And I will then go on to what a PTL is, what PTL reports look like, and what good governance in terms of implementing waiting times improvement looks like. NHS England has set an ambition to measure waiting time which is meaningful to service users. And I talked about parity of esteem last time, that being defined as timely access to evidence-based and therapeutic care and patient experience. So the new standards provide timely access by making sure that people get an appointment and an assessment quickly, evidence-based and therapeutic care by getting an evidence-based intervention and a care plan, and keep an eye on patient experience through ensuring that everybody takes a baseline outcome score, which is great. So that's the first principle, which I talked a bit about last time, making sure that we're managing and measuring what's relevant to service users and families and not just some arbitrary target. The next principle, which I'd like to talk a little bit more about today, is about managing someone's whole pathway. So the new NHS England standards from the autumn will be pathway based. Which means it's measuring for the whole experience that somebody has. So what does that mean? Why is it important? So we know that service users want timely access to help, and it's important to measure the real waiting time, which is the waiting time that the service user experiences. Most electronic patient records, most EPRs don't show you this waiting time, or at best they show you in little individual bits. Because basically, if I need help, and we've established the principle that it's important to measure from when someone starts waiting to when they get help. It doesn't matter if I'm triaged or assessed in a single point of access and then referred on. It doesn't matter if I'm referred between different teams within your organisation or even within different organisations. It doesn't matter if I need more than one intervention to really help me to get better. It doesn't matter if my data is stored on different systems and spreadsheets and down the back of drawers and wherever else it might be. It doesn't matter if I don't attend appointments or if I rearrange appointments. There might be good reasons for doing that. It doesn't matter if I go on holiday. That's a perfectly reasonable thing to do, particularly considering the length of time that people are currently waiting. And it doesn't matter if I attend an appointment, but that appointment doesn't give me the help that I need for the problem with which I presented. I went to see my GP or my drop-in centre or whatever it was, and I needed help. Until I get the help that I need, I'm still waiting. And any administrative steps that are inserted in that way don't mean anything to me as a service user. So the principle here is we need to measure the experience of the person in terms of getting help, and that means looking at the whole pathway and joining that up. Unfortunately, the new waiting time standard, which NHS England are going to start measuring people against in the autumn, that people are actually going to be performance managed against, does not measure from referral getting help. It just measures from referral to a first or second contact. So it's a contact-based measure. But it is a pathway-based standard. So in line with that principle that I described of making sure that the pathway is reflective of what happens to the service user rather than individual administrative steps. So referrals to and between different teams are linked through a complicated algorithm on your EPR. And I've certainly never encountered a mental health EPR which can give you the information that you need in order to manage waiting times in the way in which they're going to be looked at for the future. And I've certainly heard a number of people making the mistake of thinking, oh, our EPR has got waiting times functionality, we've already got that covered. In fact, I spoke to the director in a mental health trust only on yesterday, in fact, who said that when she started, she'd asked the question about how long their waiting times were and was given 3 different answers by 3 different people in 3 different areas of their trust. So NHS England will require from all systems a trajectory to reduce or eliminate the number of people waiting over 104 weeks by April 2025. That number will be based on a pathway-based measurement, and as far as we know, none of the mental health EPRs are currently able to report against the pathway-based measurement. So mental health systems and trusts will be subject to unprecedented scrutiny, for which many really are not prepared. I spend a lot of time working in physical health as well as in mental health. My experience of RTT, including my recent work in an acute trust, with exactly the level of scrutiny which is likely to be coming for mental health providers. Weekly reporting, month-end predictions at really detailed specialty pathway intervention level. So asking questions like not who is your longest waiter or how long did people wait last month, but how many people will be waiting over 104 weeks for family therapy at the end of September 2024. These are big challenges in terms of data and scrutiny for mental health trusts, and systems and providers need to be prepared. So on that slightly apocalyptic note, I'm going to pass over to Jo, who's going to tell us about what some of that implementation can look like from within a service.
Thanks, Michael. I mean, I think that it's sobering kind of thought of something that actually really matters. So the level of scrutiny for the people that we serve is very, very important. If we're able to put on my slide about why it matters to me, then in a sense, I think that some of the ways that we think about waiting times is what has shifted for me in my brain as a clinician in terms of kind of how we can solve some of these really sticky problems. I don't know if it's possible to get the slides up, sorry, because they haven't moved for me, or is that just, have they moved?
Which one are you looking?
The why does it matter, which is slide 10, is that?
I think I can, yeah, I can see it.
Okay, perfect. It's just maybe for me. I can see it now too. Cool. So for me, in terms of as a clinician working in mental health services, what I describe as the FUPS data, which is a Wolpert-Rutter kind of reference, is that our data in mental health is flawed, uncertain, proximate and sparse. So, but that shouldn't be a reason for not working to make waiting times better. And that for me as a clinician, the way that I kind of formulate the difficulty of waiting times is that the uncertainty of all of the data and the uncertainty within the system around wait times actually creates anxiety, so that as a clinician, I don't feel confident at assessment, telling people how long they might be waiting, what they could do while they're waiting, what might be the alternative option. So it's kind of that we can come across as quite defensive or secretive as services delivering. So I've worked in early intervention in psychosis, children and young people services and IAPT, and everyone has a slight different culture in terms of those waiting times or how you describe to people what they might be waiting for and those things. But actually kind of not talking about waiting times kind of almost makes the problem worse and makes that level of uncertainty higher. And I do think that then creates the trust and transparency issues that we wouldn't want to create. Mental health is about trust. We're asking people to trust us with some really sensitive information. And so our design is kind of wonky. So lots and lots of challenges about waiting and waiting in the wrong place. And we did some work in Sussex with our service users where kind of they also felt very blamed for sometimes waiting in the wrong place. I mean, anybody who stood in the wrong queue at a supermarket knows kind of how that can make you feel a whole plethora of emotions. And so the cartoon that I kind of have got here in relation to the co-production of solutions is part of the answer about your best practices and guidelines in terms of waiting times. And I don't mean co-production of solutions just within operational services. So I'm a really firm believer in kind of an actual team approach to waiting times. So any team or service that I have led. It's not the service or the general manager's responsibility in relation to weights. It's a kind of a joined up kind of element, and also that your experts by experience or service users can also be part of the co-production of those solutions, from everything from the digital innovations that you might use through to actually the kind of wording in letters, the texts that we might send to prompt people, all of those kinds of new things. Because actually, I think it can be very limiting when it feels like we're getting top-down kind of pressure in relation to targets, or you've got to do this, or can you try this bit of technology? It's really whizzy. AI is going to help you with your wait times, when actually you might be feeling quite fatigued just by the number of people that are waiting, or what it feels like, or what I feel like in my clinic when actually I'm seeing somebody who's been waiting already 6 months and their problem has escalated before they've even got in to see me and receive a service. So in the work that I did as part of my master's, I really spoke to people who manage waiting times about what the best practice in mental health should be. Because when you look at the literature coming out of physical health, the parity of esteem kind of begins and ends there, really, where in physical health, it feels like there's quite a lot of advice and guidance on what best practice looks like. And for mental health, especially in secondary community mental health care, I wasn't able to find that. So when I managed IAPT services, I had quite a lot of advice and guidance. I was told very specifically how I was going to manage patient waits, what that would look like, and the effectiveness measures that I would use within that pathway. It isn't quite the same in other areas of mental health care. And so actually kind of what our best practice should unlock is a lot of kind of barriers to some of the stickiness within the waiting time. So I don't offer, this slide doesn't offer a solution in terms of one best practice or one thing, but actually if we're able to work across all of these barriers, then our waiting time standards and the way that we as an organisation, a service or a family or an individual clinician kind of support people through waiting, then that should be better served and better enabled. So for me, knowledge, so your information about your standards and your clinical engagement starts with understanding that national guidance, which might appear dry or performance driven, but is really important, and also speaks to kind of the data literacy part. So I've focused very much on clinical safety of digital interventions and digital innovations within our organisation. And part of the engagement for clinicians is really looking at the way that we use our electronic patient record or any other systems that we have for patient tracking to think about, is this properly looking at the safety of the pathway? So is it supporting our safety culture? Is it supporting our quality agenda? Is it supporting our kind of NICE guidance and best practice? So understanding all of that information and knowledge is really, really important. And then we've got the motivation and engagement barriers. So if people don't feel that they're practicing in a safe way, or you as a person don't feel that the service that you're experiencing is safe because maybe you feel that you've been left on your own in a wait time, or you didn't know what was happening, that's really going to hamper the engagement of the service. So asking people how they want to be engaged with. Within the work that we did with our experts by experience, people said, I don't mind knowing, I want to know about my waiting time rather than you just kind of sending me a letter saying that I'm waiting. So how much of that communication link, and with things like patient portals, so we have a shared patient portal for Sussex called My Health and Care Record. We can push out information onto that platform, into the app, for service users to know where they are on the wait, what outcome measures they might be expected to do, things that they could do before they get to appointments. So that kind of persistence and shared effort between the care team and the service user is already starting, even though active kind of service engagement isn't happening yet for the reasons of the wait. And then organizational barriers. I mean, I think, as a clinician who sees patients, just sometimes the technology and the electronic patient record and our processes around that let us down. So I can't even see in certain parts of our organisation how my clinicians would know what a wait was, or the patient tracking list. So integrating that technology and those solutions into our practice and our culture and our clinical leadership is also really important. It can't be something that the digital team kind of they come up with a whizzy idea and gadget, and then we just kind of have to be the recipient of that. So I think kind of making sure that as an organisation that we're working for user-centred design, co-production, these words that are said a lot, but actually what does that mean? And I can give an example of it. For at the moment, we're bringing in a new electronic patient record into Sussex, and we have a expert by experience design group who'll be working alongside our clinical design group and our technical design group to design kind of the electronic patient record elements, and a lot of that will be that patient facing aspect and relating to weights, because I think, you know, that is incredibly important in terms of getting the best from the systems that we've got. We might not have a system that does it all perfectly, but we can always work to improve. So they were my main elements in terms of kind of best practice and unlocking. I also don't think that clinicians should be shy in terms of getting involved. So if there was any key message for me, for my little kind of elements here today, it is that I felt a lot happier and engaged and safer in my practice when I was more engaged in some of these aspects that might traditionally have been seen as operational. So I think any clinicians kind of need to also really think about how we can get more involved in that. It's not just a one side or another side in terms of corporate or operational services and clinical work. I hope that that's helpful.
It most certainly is. It's good to hear about what's going on in the organisation, but I'm very helpful. Yeah, for sure. Michael, I'll give some reflections shortly. Let's have your second part, Michael, and then I'll give some reflections.
Okay, no problem. Thanks, Sean. Right, so I'll carry on then. I've already talked about the kind of principles, and now we're going to talk a little bit about the practice. So I talked about making sure that we're looking at the experience of service users as a pathway. So what does that mean from an implementation point of view? So a clear pathway is needed to understand where I am, my waiting times journey, relative to where I should be, and how far I am from where it is that I need to get to. Because those are the questions that we need to answer in order to propel me through that pathway as quickly as possible. So a good pathway is dependent on a map, and timed pathways are dependent on timed milestones. Because if you're trying to get me through quickly, you need to know where I should be and when. So anyone who's familiar with physical healthcare or who's been involved in lean service improvement or any other of those kind of post-it notes on a wall kind of exercises will recognise this approach. I've used an example here of a physical health pathway, frankly, because I couldn't find a good example of a timed pathway in mental health. And given the amount of time I spent working with mental health providers around pathway improvement, I found that quite alarming in and of itself. A mental health pathway is likely to include kind of milestones like when was I referred, when was I triaged, or when was I dealt with through a SPA, a single point of access, whatever the routine might be, when was I assessed, when did I agree to a care plan, which hopefully was co-produced with me? When was my first routine outcome measure taken? When did I receive my first line intervention? What was it? Is that evidence-based for my presenting problem, etc.? And measuring those milestones is the next kind of challenge for mental health providers. So measuring the milestones is dependent on our ability to record them accurately on our EPRs. And in order to be consistent with the expectations laid down by NHS England, that has to be recorded and reported externally using SNOMED CT. So if I present with depression, what are the interventions which our organisation is able to offer me? What's the first line intervention? And then what's the SNOMED code? How can I record that electronically from the SNOMED CT interventions rest set, which says what was that intervention? What's the code that represents the assessment that I'm receiving? What's the code that represents the fact that we've agreed a care plan? And similarly, we need to be recording the outcomes which are appropriate for each pathway. These can be fairly generic, so the kind of recommendations reflecting back on the parity of esteem thing, that we're looking at the quality of someone's life using something like Requal. We're looking at whether or not we're getting the thing that I need, the help that I need, using goals-based outcomes, or whether or not I'm happy with my life and with the support that I'm receiving. So measuring that patient experience using something like dialogue. So we need to know what the pathway should look like in order to get me through it as quickly as possible. So once we've established what the structure should be, then we need to make sure that we've got that data all in one place. So Joe talked about the kind of challenges that people experience in mental health trusts. because not only are people not routinely referring to people's waiting time, even if you were really proactive and really wanted to know how long someone had waited across their pathway, not for an individual thing, but their whole experience, the thing which is actually important to service users, then you actually probably can't find out from most mental health EPRs, even if you wanted to. So we want to make sure that people get the right help as quickly as possible. And using that, we create something called a PTL, or a patient tracking list. This is a list or a data source, or whatever you want to call it, of everybody who is waiting for something. And realistically, if you're engaged with healthcare, whether it's physical health or mental health, unless you're actually receiving the thing, then you're probably waiting for something else. So most people who are under the care of an NHS provider are probably waiting for something. So it's not just people who are waiting for assessment or waiting for first treatment. It's anybody who needs something from you, who would benefit from getting that thing sooner. They're waiting and they should be visible to you in a single corporate visible way. So to get people the right help as quickly as possible, we need to know in one place, everybody who is waiting, how long they have waited, what they need, and when they need to get it. So this is a PTL, or a patient tracking list. So getting that data right and in one place is a real challenge. Just as an example, and I hope I've explained kind of concisely enough what a pathway-based PTL means, I wanted to mention the impact where we introduced this approach in a mental health trust last year. This mental health trust already had Rio, and they already had waiting lists on Rio. But when they moved to a pathway-based unified PTL, they found around 1,000 pathways that they hadn't been tracking up to that point. Obviously, those people were already there, but they weren't visible to the organisation in a joined up way. They were able to really significantly reduce the number of people who appeared to be waiting over 52 weeks for their initial assessment. Obviously, initial assessment is not the be all and end all, but it's a start. And they saw a huge improvement in waiting times within just 3 months. Coming back to my point in the beginning, this isn't about producing more staff or creating more money or resources. This is just about making best use of the things that you've got already. So the approach you are used to in mental health, using the basic stage of treatment-based waiting times that are available through most mental health EPRs, they do not give you what you need, and they limit your ability to help people quickly. So we talked about the principles of having a pathway. We talked about how you do that from a technical point of view in terms of getting the data all in one place and what it needs to tell you. So then what is it that you do with it? So I talked about what goes into a PTL. How do you use it? I think Jo said in her earlier section, it's important to really keep it simple for the user and for patients. And a good PTL should keep it simple for clinicians and for managers so that they were looking at the patients that they need to look at in order to get things done. So a good PTL report will contain everyone who's waiting, but it highlights where the action is needed. You don't need to be looking at thousands of people day in, day out, week in, week out. You need to know the people who are important to the stage of the treatment pathway that you're dealing with, who you are supposed to be taking action on. It tells me at a glance what happened last to that person, what needs to happen next, and when it needs to happen by. So PTL reports showing the right bit of the overall waiting list relevant for you are a key part of delivering on shorter waits. And they show you the pathway detail when you need it so that I can easily track anybody throughout their journey from referral to getting help and beyond. They need to be designed so that anyone can easily sort and filter to make sure that they're looking at the appropriate people or appropriate appointments or the appropriate outcomes or whatever else it might be, so that the different roles are all catered for. So as a manager, it shows me where in my organisation the bottlenecks are that I need to be worried about. If I'm a team leader or service manager or something like that, it shows me which interventions or which clinicians are under pressure or I might need to provide extra support. If I'm a clinician, it shows me who I need to worry about on my caseload or on my waiting list, because the people who are waiting for your services are just as important as the people that you're currently providing care for. If I'm an administrator or a booker or something like that, it shows me who I need to book next, what it is they need, and when they need to have it by. And if I'm a service user, so we talked a lot last time from Alistair's experience in terms of the lack of information that people receive when they're waiting for something and how anxiety producing that can be. And Jo talked about the importance of making sure that people are engaged with at every stage along their waiting times journey. So if we're able as an organisation to accurately track where people are through their pathways, what it is they're waiting for and when they need it by, then we're able to communicate that in a meaningful way to our service users and manage some of their expectations and anxieties. So that's what a PTL report should be delivering for us. So then finally, you'll be pleased to hear, I will stop talking soon, once you've got the data right and you've got the reports right, having the right information presented in the right way, the final piece of the puzzle is getting the right people together to turn that information into action. To get people help more quickly, we need PTL meetings. And this isn't things, you know, all of the things I'm talking to you about now, these are not things that I've made up. This is a well-versed and effective technique which have been used in elective care, in physical health care for decades now to manage waiting times. So this is about saying, here's the challenge that mental health is now facing. Mental health is now under a level of scrutiny which hasn't been under before, which affect the waiting times. And there are some ready-made solutions that can be implemented to help us to manage people more effectively. So PTL meetings need to take place at different levels within your organisation, but they all need to be run properly. They need to be chaired by someone senior to make sure that that's a meeting where things get done. So the different hierarchy levels within your hierarchy, whatever that might look like, whether you have divisions or whatever it might be in your trust or in your provider, at that kind of pathway or service or team level, you have a PTL meeting at the same time and in the same place each week, whether it's online or in person. You make sure you include all the people who are able to take action, like bookers, clinicians, managers, and have a really detailed look at all the people who need an appointment, what appointment it is they need, when they need to get it by. And if you're not able to deliver for those individuals the things that they need, then there needs to be clear escalation to the next level up, if you like. So for example, that might be to a divisional PTL meeting where you're not looking at the absolute granular detail that you would in your service meeting, but you're dealing with escalation of issues from the meetings in the service. And you might be looking at learning from people who've recently waited too long and trying to understand what you can do in terms of improvements in your service to improve things for the future. And then that eventually kind of percolates up to your trust or organisational level PTL meeting. This would typically be chaired by your COO or someone in that kind of role. You'd be looking at the very longest waiting people by exception, where something needs to be done in terms of escalations from the other PTL meetings. You'd be looking at performance against trajectories, such as the ones which NHS England will be demanding from you from the autumn of this year. Be looking at some kind of more long-term, longitudinal KPIs in terms of the shape of the PTL, any changes in demand, any forthcoming changes in capacity, and you'll be looking to learn from the themes that you'll experience of people who have waited too long, so that at an organisational level you can make more structural changes, trying to bring about improvements for the future. So just before I hand back to Sean, so in summary, talked about the kind of different steps along the pathway to get to effective management of waiting times in mental health. So it's defining your pathways and your milestones, making sure that you're able to record the data on your EPR, pulling it all together onto a PTL, making sure you've got that PTL presented in a meaningful way to people so that they can actually take action, and making sure that you've got the right governance and escalation in place to do something with the data and to get people help as quickly as possible, which is the purpose of this entire exercise. Before I hand back to Sean, I just want to very quickly flag, given that the new mental health waiting time standards are imminent and NHS England will be publishing the data in a month or two's time, we've developed a very quick quiz, which we've put down as saying 3 to 5 minutes. I definitely think it's more on the 3-minute end of that, but it's a moot point, where you can fill in that quiz very quickly, get some feedback initially in the quiz window, but we'll also send you quite a detailed report in terms of what your waiting times data as nationally reported is showing at the moment, and some suggestions about how you might be able to improve that. Should only take you a few minutes, so I encourage you to click on the link, which will come out in the email to you after this webinar, take the quiz and find out where you stand. Anyway, that's it from me. I'll pass back to Sean. Thanks very much.
Wonderful. Very good, Michael and Joe. That's really, really good indeed. I should give you some reflections on that. And then, yeah, just to remind you, put your questions in, and Lucy from Acumentice will help us bring the questions together. We'll have a little discussion. We've got a bit of time, which is really good. Well, firstly, thanks to everybody, not just Michael and Joe, but all of you that are working on this, because, you know, just managing waiting times, what we mean by managing waiting times, be more effective, more efficient. And we owe service users and our population to do what we can. Now, but I'm under no illusion. I've been around mental health for a long time. It's a complex world out there, and you are dealing with very complicated service user groups. It's not, I mean, unlike physical healthcare, where you've got a sort of confined hospital, mental health is typically spanning community, social care, prevention, the independent sector, voluntary sector, statutory providers. We add complexity for you. We're very good at that. And we thank you for that, because it's tough. Just a couple of points about sort of national priorities that have been reinforced by this new government that are coming in. It's waiting times, particularly reference to emergency departments. How does that relate to, how does any of this, what I'm about to say, relate to community mental health waiting times? Well, it all does, because community mental health services, I remember managing them many, many years ago. They're at the core. We often talk about acute inpatient services, our core, but community mental health teams are our core services. People going through the system, go through community mental health teams, and in recovery, come back out. They're absolutely essential, and that needs to be fluid and effective and efficient for us to have those flows moving. And we can't do that without monitoring, measuring, and managing waiting times. So waiting times, emergency department waiting times. So we've got people in acute hospitals waiting in A&E with a physical and mental health, and the mental health wait is high, very high in some cases. We've got acute hospitals that have organised in conjunction or not in conjunction with the mental health trusts, wards for an emergency mental health assessment, awaiting treatment. They can be good, but they can also be very difficult, because there are delays in getting back out into the community, or indeed treatment into an acute inpatient hospital. Our acute inpatient hospitals are running at maximum occupancy. Worryingly, I heard yesterday that the discharge, the medically fit for discharge levels are really soaring. They're going up. So we've got people in, and we can release that when we've got effective community mental health teams where you're managing your waiting list and you've got capacity to take people on from acute inpatient units. So the whole thing is interdependent. We've got NHS England they're ratcheting up now, and they will say no more out of area placements. How realistic is that? It's open to debate, but that again has effect on community mental health and the waiting times, and also the reform of the Mental Health Act, which nearly got dumped actually by this government. We weren't sure whether it was going to be in the King's Speech. It is. It's got to be good news, because with that will have to come investment, and it relates to, of course, community mental health. Without a shadow of a doubt. So those are the sort of reflections on the national side of things. I think one of the things I'll do from this is feedback to Claire's team, because we're in the middle of, aren't we, community mental health team transformation, and this whole business of managing waiting times more effectively. There might be somebody on the call from the national team, but we need your help in making sure, particularly as in the autumn, as Michael says, we're going to have standards to relate to. The other thing is that we mustn't forget the independent sector, use NHS money commissioned by NHS services. And I was talking to the chief execs of the big players yesterday, 6 of the big provider. They're all looking at how step down facilities, community, how they can help with the community. So it's managing waiting times across the sectors, which might make things a bit more complicated. And also the voluntary sector, we are saying quite clearly that we need to scale up big time the voluntary sector. We can't deliver on the mental health plan without the voluntary sector. Mind rethink, when you think about learning disabilities, well, choice support, turning point, those are the big ones, and there are so many other smaller ones that work either as part of the supply chain. We've got housing associations that are specialising in care and support. These are all really important players in this, and it adds help, but it also adds a level of complexity. I agree with Joe and others about co-production. In mental health, we don't do anything without co-production. We've got lessons to teach the wider system about co-production. We do it quite well. We should be pleased with the way we do that. We can always do better, but and then I think the other thing is about, again, managing the waiting times. You need the throughput. You need for people managing the waiting times, for service users to have really maximum chances for mental health recovery. We can only do that by making sure that we've got the social determinants in place. The two main ones are housing and employment. Both of those seem to be picked up by the current government as really important. So there's a housing strategy to build to build more houses, which would include supported housing. That's essential for us to, manage waiting times. And I think those are the main things. The other thing, perhaps as well, but I mean, Lucy will tell us what questions are, but I'd be interested in Michael and Joe's view about Geraldine Strathdean. She was a president of the Royal College of Psychiatry. She did a review in data for mental health, particularly around acute inpatient units. But I wonder whether that had any help in, pushing forward the agenda of managing community mental health team waiting times. So anyway, Lucy, over to you. Let's get some questions going.
Great. Thank you very much, Sean. Michael and Joe, I don't know if you want to answer Sean's comment there first before we dive in.
I might leave that one to Jo, given her academic background on this.
I've heard Geraldine speak to the data around inpatient, and what I've found really interesting about that was the flow aspect in terms of, you've spoken to it really, Sean, is that about the whole system, and actually community mental health is often not looked at by maybe the system, the ICBs, because kind of we're seen as A&E waits are the problem, and kind of how do you move that on? Acute inpatient is the problem, but actually where you might find the most stuckness, or where service users themselves kind of maybe want some of that innovation or transformation, is within the community mental health teams. And I think with the neighbourhood teams and the way that we're moving into that kind of more primary VSE kind of model, then making sure that we have really good intelligence around the flow within that is as important as what we offer. I think when I developed some waiting time strategies with the YMCA within Brighton and Hove, it was really interesting, the culture difference from a third sector organisation that actually didn't really have wait times compared to the NHS, where we kind of see waiting as almost, and I say this not in a proud way, but we see that as something you have to endure to get the service, and actually kind of zero wait times or something different in terms of what else can we provide if we don't provide this, is a different way of looking at things, because I think we in the NHS get quite caught up on our treatment and the kind of tiered service nature, therefore meaning kind of the more acute, the better the care. I'm not sure I agree with that at all.
And I think it is also worth reflecting on, only a few days ago, we saw the Learning from Deaths inquiry published over in Norfolk about a large number of people over the years and their experience. And one of the big headlines from that was the number of people who were on waiting lists, who were not being managed on those waiting lists, who weren't in and hadn't been in active treatment and didn't seem to have any immediate prospect of going into active treatment. And so it's not just about that. It's only when you become an inpatient that somehow you then kind of sort of hit the news from an ICB perspective. Improvements to community mental health services are key to not just managing demand for people wanting to access inpatient services, but also managing safety, managing those people effectively.
Great, thank you guys. So looks like we've just had a question through from Dave West at Sussex, saying, working on the new standards and understanding construction/data, note the focus on the front end of the pathway. Any thoughts about how we develop process and data to manage patient flow and not be focused on the front door?
Thanks, Dave. Yes, I think as I kind of implied, I think in one of my slides, it is slightly unfortunate that the interim target, let's call it, that's being looked at from the autumn is definitely focused on the front end of the pathway. But really the principles that I talked about in terms of having a unified VTL, in terms of having the right reports, in terms of having the infrastructure in place to make sure that you're managing and escalating people appropriately, they're applicable across the pathway. So if you need to implement those things, and I would argue strongly that you do, in order to meet the immediate kind of pressure around meeting a waiting time standard for the front end of the pathway, then those exactly same things that you're going to be implementing can be used just as effectively throughout the pathway. When I'm talking about a time pathway, I'm not talking about a time pathway to first assessment or a time pathway to your first line intervention even, but every part of the pathway should be timed, every part of the pathway should be on your PTL, and all of those people should be managed irrespective of what it is that they're waiting for in the same way and using the same tools and techniques.
Great. Thank you, Michael. I hope that's helpful, Dave. So we actually had a few questions come in beforehand. I've just got one for you, Joe. As Sean mentioned, the new government mentioned the mental health reform in the King's Speech recently, but how positive are you that they will actually take decisive action on mental health waiting times? And what one action in particular would you like to see them introduce?
Oh, that's a really good question. I think we have to believe that mental health will have more attention, because I think that there's been such a we have to, because of the safety aspects, because of the fact that kind of our services need that level of scrutiny. I think how we balance targets and performance, the thing that I would like to focus on is actually kind of goes back to Dave's question, is the whole pathway approach. As a clinician, I don't work in a triage hub. I work in kind of the treatment element within our services, and actually there's not a lot of focus or expectation on me in my clinical role to be part of some of the solutions for waiting times. So actually, I mean, it's not to kind of the visual that you have really in terms of people moving through your wait times, is that if everything is all focused on the beginning, the kind of bulge of the snake, if you like, in the treatment or the capacity or the attention that we give that there's still as much kind of discontent in that element. So I would like to see that whole pathway look of things, and I think that kind of it's our job as kind of part of the mental health system's job to really highlight kind of some of the wonkiness of the targets that we're expected to deliver upon, and I think that can be quite a joined up element. Part of the problem has been because our data hasn't been good enough to kind of articulate that argument. It isn't easy, but it's not impossible, because I think we need to move together to kind of really highlight that. And if I was a service user or I was a parent of a young person waiting for my kind of treatment, where I work in children and young people's services, I'm as interested in both. I don't just want the assessment. I want kind of the whole package, and I think we have to remember that.
I mean, yeah, if I could add to that's great, Joe. And I so much I agree with Joe that they're going to have to take this a bit more seriously. I don't think we can. Yeah, I think the last couple of years we've suffered a bit from mental health being a lack of a priority at national level, where we had years of it being fairly high up. Simon Stevens, Chief Executive of NHS England, was, I'd say, very much partly responsible for that. But then you go back to political leadership with Norman Lamb and others that put mental health firmly on the political agenda, and that we've reaped the benefits of that without a shadow of a doubt. That's been on hold for the last strategic period. I do think that this current government is saying the right things. Wes Streeting is certainly talking about mental health. I mean, he had objectives, sort of targets for mental health but when they were in opposition, way before. I mean, months, last Labour Party conference, I remember him talking about targets for mental health around community children hubs, workforce numbers. The chief execs of the trusts were asked to go to, in this region, the south, this region means that where I'm sitting, southeast region, met Wes Streeting last week, and it was, I mean, they came out quite positive, and I think that's always a good yardstick if they're saying that. The chief execs will know whether there's some meaning in what's being said politically. And mental health was given a bit of airtime. They are saying that waiting lists will mean for mental health as well. We just need to put that in action. And I think if NHS England are making establishing targets to be implemented in the autumn, that would indicate we are being serious about this. So that's got to be good. We mustn't have a session like this without talking about the workforce, because anything we do about managing waiting times, you need people to manage it. And you know, as we go forward, I hope this current government sort out the industrial disputes that we've had. I hope they stick to their improvement of numbers for mental health practitioners. Nursing numbers are going up for sure, but actually, when you interrogate the numbers, we're really only going back to a few years ago. You know, because we lost a number of mental health nurses within the workforce, and certainly learning disabilities, big time. So the numbers are going up, which is encouraging, but they need to go up even more. And we need to be a bit more flexible and innovative about the workforce. So I'm a big fan of peer support workers, scaling that up to much more significant numbers than we've got now. And the use of the voluntary sector, they've got a ready-made workforce in the voluntary sector. They're all very busy, but you know, you see some models around the country now whereby clinical staff and trusts are working better with the voluntary sector, support workers, and it's fantastic, you know. So we need to, as I say, we need to scale that up a bit more as well. Thanks, Lucy.
Great, thanks, Sean. Just to say, Joe as well, Dave has come back and said thank you. And it would be helpful if the national framework created visibility of the whole pathway. So I guess that moves kind of quite neatly on actually to another question we've received, which I think is probably best for you to respond to, Michael, perhaps initially. But quite a sort of big question here, but how easy is it to move to a pathway-based PTL?
Crumbs. Well, I don't want to go. I mean, in a sense, I guess the fact that we've taken 2 webinars, even describing what the process looks like, does sort of underlines the extent of the culture change and technical change which is needed. But I guess the key message I would give is that there's always something that you can do. You know, there are tools and techniques out there. You know, Joe knows a great deal about them, although she might not want to blow her own trumpet. And you know, organisations like us are obviously able to help with that, as well as there's a lot of guidance and support available from NHS England. You know, getting the data right. It sounds like a boring thing, and there's not loads of service users and carers out there clamoring for better mental health data, but actually getting those underpinning foundations is key to enabling a great deal of this stuff. So I would really encourage people to get to grips with that and to make sure that kind of joined up approach and kind of engagement and co-production approach that Joe described between staff in the organisations, between service users, and between kind of BI and informatics professionals to make sure that we're able to tell the story with our data and use that underpinning to then use some of the tools and techniques we talked about in terms of how you use the data, how you understand your waiting times pathways, and how you get people through them as quickly and effectively as possible.
I think the other thing, Lucy, that I would add to that, one of the things that I learned quite a lot from working in IAPT or NHS Talking Therapies was that as a clinician, I've been always taught to think about the exception. So how can I adapt this treatment or this thing that I'm doing for this one particular person, because I'm, you know, very into kind of making sure that I'm making the most of their strengths. But when you work in terms of high volume numbers of patients waiting, creating rules for the 1 in the 99 actually makes quite messy systems. So there's something in terms of how easy is it for your to implement any of these things. There's something about the way that it's not about not looking at individual needs, but actually sometimes we don't do enough when we're thinking big volume. So actually for these 99 people, is this going to be okay in terms of a text reminder or this way that we're going to work as an organisation, rather than thinking of all the kind of the one person who might not have a mobile phone or data or all these things, because we run into the kind of scenarios where we almost are exclusive when we're trying to be inclusive. And so there's something for me about all of these strategies kind of thinking about what would have the biggest impact over the largest population, because actually the problem is quite widespread rather than very individualized. So that would be the other, like in terms of kind of the sort of the more less about the actual doing, but more about the headspace you've got to be in. That's how I have found my way through some of these stickier problems.
Great. Thank you very much, Joe. I think that's all the questions that we've had today, Sean. I'll hand back over to you.
Fantastic. Well, look, I hope everybody's enjoyed the webinar. We'll let you have a bit of time back. And as it says there, part 2. So we've clearly got a third part, Thursday, September the 5th, and more information will be sent out. Can I just thank Joe and Michael and Lucy? Great. Well done, Acumentice. That's fantastic. And see you all soon.
Thank you.